Joining me now, Dr. Scott Samlan, who's an emergency room physician at Mount Sinai Hospital, and Dr. Rochelle Walensky, Chief of Infectious Diseases at Massachusetts General Hospital. Good to have both of you with us this afternoon. And Dr. Walensky, I want to start with you. We are hearing from local leaders, from governors, also from doctors. Rigorous testing is really going to be the key to returning to some kind of normalcy, whatever that new normal is. When you think about the testing that's needed, is this more diagnostic testing? Is it antibody testing? What do you see as the need?
Good evening, Erica. Thank you for having me. I think it's actually two-pronged. I think we need to do the antibody testing to understand how much of the population has been infected before, maybe asymptomatically or mildly symptomatically. So we need to understand how much protection is out there. Is there some level of herd immunity that we might be able to rely on? On the flip side, we really need to understand how much virus is still circulating out there. We need to do the viral tests, the NP swabs, the nasopharyngeal swabs that everybody has been talking about. And that I think we really need to do in vast quantities. I think we need to be able to test people anytime they have any symptom at all. That's what we're doing in healthcare workforce. And we need to halt that transmission immediately, which means we need to do an immediate contact tracing. One important point I think that has been really overlooked is that the testing alone does not fix this problem. It's what you do after you have a result that really is so key and very important. So people who are diagnosed with COVID, once they have a test, they need to understand that and change their behavior immediately. They need to isolate at home because the more people they contact, the more likely they're going to be transmitting it elsewhere. They need to do immediate contact tracing to make sure that those people who they might have contacted can also quarantine.
Such an important point and a reminder why we are told repeatedly we all need to behave as if we have the virus. Dr. Samlan, you know what Dr. Walensky says about testing, that you need to be able to test anyone at any time with any symptom. Have you been able to test every patient you'd like?
So that's a great question, and thank you for having me. We just implemented these rapid testing over the last week in the hospital, and that's been a paramount in terms of who exactly needs to go home, who can be admitted to the hospital, where exactly we're going to place those people in the hospital. So it's been paramount.
So that has changed things for you. When we look at the testing itself, the National Academy of Sciences cited one study of 51 coronavirus patients in which the swab tests that were used produced a false negative in 16 of them, so 30%. Dr. Walensky, when you look at that rate of 30% false negative, listen, I am clearly not a doctor, but those numbers stood out to me. Does that concern you, and how prevalent do you think that might be?
You know, this has been probably among the biggest challenges that we have had in monitoring patients in the hospital. How much can you trust a negative test when the patient is presenting with symptoms that are classic COVID, or when you know the patient has had an exposure? And in fact, in many places, we know that they're doing 2 sequential tests. In our hospital, we are reviewing the charts carefully and then doing 2 sequential tests because we're not sure we can trust a single negative. And that implies actually what we do from a public health perspective is that anybody who tests negative outside who has symptoms that might be suggestive, we would then suggest a follow-up test, which gives you a sense of what the volume is of tests that we really need.
It absolutely does. There's also this new study, Dr. Samlan, that found some COVID-19 patients may experience neurological problems, but not respiratory problems. And I'm just curious if you've encountered that at all, and if that concerns you that we may be dealing with underreporting based on that.
Of course, this is concerning because this is a novel virus. So we, at times, don't know how this can present. Sometimes people come in with abdominal pain. We do a CAT scan, and on their X-ray or the CAT scan, we could see images that be suggestive of COVID. So this is presenting in a myriad of different ways, and that's the scary part of this disease.
So because it's presenting in so many different ways, another emergency room physician I spoke with here in New York told me a couple of weeks ago, whoever walks in, we just have to assume that that person has COVID, and that's how we go about, treating them. That is their baseline. Dr. Samlan, is that what's happening in your hospital?
Absolutely. Every patient who comes into the hospital, we presume that they have COVID-19. Even if they're in a car accident or ankle sprain, we do screening examinations, screening questions, but we treat every single patient just like that. We don PPE to make sure we don't expose ourselves or our colleagues, but we treat every single patient who comes to the ER as they in fact do have COVID-19.
Dr. Walensky, there's been a lot of talk, especially this week, about the racial disparity. We know that no one is genetically or biologically disposed to this virus. It can attack anyone. That being said, there's a disproportionate number of African Americans who are becoming infected. And there was a study, I believe it was out of Boston Medical Center, that found 80% of its coronavirus patients were either African American or Hispanic. Are you seeing that intense of a racial disparity at Mass General?
Tragically, we are. And, you know, this disease, like many other epidemics, highlights the disparities in equity and healthcare that we have in this country. It highlights several things. One is people who have had less access to healthcare historically are more likely to have hypertension, diabetes, and many other things that put you at highest risk. The other thing is that we know that this is a disease of crowding, right? People who are close together, people who are undomiciled, people who have many people living in one space are more likely to transmit. And in fact, that highlights yet again the inequities and how it can tragically impact such vulnerable communities.
So many lessons coming out of this and so much work to be done. Appreciate everything you are both doing and your colleagues every single day. Dr. Scott Samlan, Dr. Rochelle Walensky, thank you both.
Thank you so much.
Just ahead, California is taking steps to outfit entire